Hi, welcome to tonight's talk. I'll be going over common sports-related knee injuries and the latest treatment options for you. My disclosures, I'm a consultant for DePuy MyTech. Today's objectives are to understand the basic anatomy of the knee, along with the common knee injuries and the treatment options for them. And no talks not complete without basic anatomy. And what we'll be going over are the major ligaments of the knee along with commonly injured structures. And so it's important to know what normal looks like so that we can fix it when it's injured or if it's abnormal. So the main structures of the knee would include the ACL here, highlighted by the laser pointer, and behind it the PCL, the meniscus here, and then the lateral collateral ligament and the medial collateral ligament. And this is the front view of the knee, and this would be the posterior or the backside view of the knee. Here's another view of the knee from the side, and it's a cross section of it. Here you can see the kneecap, your femur, your tibia, the meniscus, the quadriceps tendon, and the patellar tendon. Here's another view of the anatomy of the knee. Here's a top-down view of it. You have two meniscus in the knee. You have your lateral meniscus here, or the meniscus on the outside, and then you have your meniscus on the inside here. They're C-shaped structures that can be frequently injured. Here's the kind of microanatomy of the knee, where it shows the circumferential fibers of the meniscus. The meniscus helps to serve as a shock absorber in your knee so that your knee does not see so much shock when you're running, walking, or sprinting. And here's a view of the blood supply. As you can see here, the blood supply is on the outside of the meniscus here, and the inside lacks a blood supply, which is important for our treatment options. We'll be going over common knee injuries, which include meniscal tears, articular cartilage lesions, intra-articular and extra-articular ligament tears, which include your ACL, your PCL, your MCL, and your LCL, patellar tracking and patellar alignment, along with what I consider extensor mechanism injuries, or injuries to the ability for your kneecap to function correctly and for you to kick out with your patellar tendon and your quadriceps tendon and a patella fracture. Generally, we'll kind of go over how we fix things and how we get there. As far as how we get there, the majority of these injuries can be fixed by knee arthroscopy, and what that means is the surgeon pictured here can access the inside of the knee using arthroscopy, and what that is he has a camera here that he can view on the screen here, and he can see inside the knee joint through two small incisions, and so that you don't have to make a big incision to access the knee joint. And this is kind of what it looks like in the operating room. And here's a kind of a closer view of the portals that we make, or little small incisions where we use an arthroscope or a little camera. And what we can do is we can go inside and look at the knee here. Here he has a probe in one portal and a camera in another portal. And we are viewing inside of the knee using a camera, and that we can view on a screen, much like you're watching TV. This is what it looks like here, and here's another view of the camera setup. These are the different types of portals that you can use to access the knee. Depending on what we do, we may have to make more than one portal to access the knee. Typical knee arthroscopies are our outpatient procedure. You can go home the same day. Usually it's general anesthesia, or you go completely asleep. This can also be done under local, where you don't have to be completely knocked out. There's very little blood loss, and it's very minimally invasive. The first injury up is the meniscus tear. It's probably the most commonly injured structure of the knee. Most people complain of some popping or clicking. Sometimes you can feel like your knee gets stuck or locked. This would be your bucket handle tear. It's usually diagnosed by exam and MRI. It's sometimes called the hangnail of the knee, because much like a hangnail on your finger, when it pulls or it tugs, it can cause a lot of pain. The treatment depends on the severity of the injury. The typical view of a meniscus, it's nice and flat like this here. And here's a probe in here, and where we kind of probe and kind of pull on the meniscus to see if it's stable or not stable. This would be an injury here to the meniscus, and here, instead of it being flat like in this picture here, you can see that it's torn and it's flipped up. And you can imagine if you're going to put weight on this or turn or twist a certain way, this can actually get stuck inside the joint and pull and tug and cause a tremendous amount of pain on the joint. And here's another view of the meniscus tear here. Here's kind of what we use to go in and trim it out. It's called a punch. And then here's another view of a meniscus that's actually flipped inside the joint, and that should actually be more posterior and in the periphery. The types of meniscus tear can be classified in different patterns here, and depending on what the pattern looks like depends on your treatment. So if it were more of a radial tear here, where it's kind of straight back like that, usually these get trimmed out, or these flap tears here. The ones that we talk about fixing are these peripheral tears that are closer to the outside, and that's where the blood supply is, and these are more amenable to repair with suture. Then you have your longitudinal tears here that can sometimes flip forward, and those are usually amenable to repair too. And so for the tear patterns, we break them down into different areas in the front or in the back, and different zones, whereas 0, 1, 2, and 3 depends on how we're going to repair it. So typically on the inner zone here does not have very much of a blood supply. These usually get trimmed back, and then 2 on over you can usually fix. There are different types of repair techniques depending on where you're operating. Some are the inside out versus all inside and versus an outside in. And it all depends on where in the meniscus it is and surgeon technique and familiarity. Here are some of the instruments that we can use to fix it. Here's a camera here, and kind of going through another portal. We pass suture through the tear itself here. And here's a different way of doing it, where this is called an all inside repair, and this is a little cartoon sketch of a tear here, and we put sutures across there to kind of stabilize the meniscus. And these are other tools that we can use to fix the meniscus here. And here's what I would call a peripheral tear here. Here, there's a good blood supply. As you can see, there's red back there, and what we do is we pass a series of sutures here to stabilize the meniscus, so that when you pull on it with this probe here, it doesn't want to displace into the joint. There's been a newer type of tear called a Meniscus Root tear that I've been fixing a lot of these days, and it helps to prevent arthritis. But what that is, it's a tear in the back attachment here. Here's the tear here. Here you can probe it, and it's pretty unstable, and what we end up doing is passing suture through it and tying it usually over a button on the front side. And this is a little schematic here we have of it here. And we pass some suture through the back of the meniscus here and sew it back down. Here's a view of a debridement here, or just kind of a cleanup procedure. You know, you may have heard of your favorite athlete having some torn cartilage, and he goes in for surgery, and he comes back out 2 weeks later and he's able to play again. Usually he has a little tear of his meniscus here, and you come in with this little thing called a punch. It looks like a nail clipper, and you go in and smooth it down here. Here are some more pictures of what a meniscus tear looks like here, and here's a little probe in here that's our little guy that helps us figure out whether it's not stable or unstable here. And here's a view of the cartilage and the meniscus here that's torn. Recovery depends on what we do. Meniscectomy or cutting out the meniscus, usually 2 to 4 weeks for recovery. You do some PT, probably for about 2 to 4 weeks, and usually you're pretty good. The meniscus repair, because we're protecting the repair, you have to be on crutches from anywhere from 4 to 6 weeks. You're going through PT, and you're looking at a full recovery anytime, 4 to 6 months. So cartilage is the smooth covering on the end of your bones here. It's some of the slickest substance known to man. It helps cushion the knee and allows for near frictionless movement of the joints. Damage can lead to joint pain and arthritis. Injury can cause swelling, clicking, and pain. Here is a normal view of cartilage. It's nice and smooth, glistening white. Here's some damaged cartilage here. where it's basically down to bone, surrounded by some normal cartilage here. The articular cartilage lesion, here's another view here, and there's different various treatment options for it. Here we're poking some holes in there. It's what's called a microfracture, and we allow it to stimulate some healing and with some bone marrow. Here's another view of a chondral lesion here, and here you can see that the cartilage is kind of loose, and you can imagine kind of walking and bending your knee and having this kind of pop around would not be too fun. So treatment options would be abrasion arthroplasty, or just kind of smoothing down the torn edges, a microfracture, which we showed before, poking some holes in there. Osteochondral allograft, or OATS procedure, is here are little cartilage plugs that we can fill in the gaps here. And then you could talk about trying to replace the cartilage with biocartilage, which is a cadaver cartilage, or using your own cartilage called an ACI procedure, or autologous chondrocyte implantation. Recovery depends on the type of surgery we do. If it's a simple cleanup, you can usually put full weight on it, crutches, and you can get back to doing everything maybe 2 to 4 weeks. Transplant, you're looking at a little bit longer recovery, and with a cartilage cell transfer, you're looking at sometimes 1 year plus to get back to doing everything you like doing. So the cruciates would be broken down to your ACL and your PCL. Your ACL is a very commonly injured knee structure, along with your PCL, not so commonly injured, but your ACL allows you to kind of cut and pivot without any issues or any knee giving away. If you do have an injury to this, you can have problems running, jumping, and cutting. Here's your ACL, kind of goes from front to back there, and then your PCL is further in the back. And then in order to rebuild your ACL, you need to know the normal anatomy. It has 2 functional bundles, the anterior medial and posterior lateral. Here you can see it coursing from the lateral femoral condyle to the front of the knee here, and prevents anterior tibial translation, prevents tibial rotation, secondary stabilizer to varus and valgus stability, and depending on how your knee is flexed, different parts are tight. Here's the attachment on the femur here, and we need to know where this is in order to reconstruct it properly. Here's a CT scan study, along with a view from the side on the femur here. Here's what a torn ACL looks like when you're looking at it through an arthroscopy. These are actually the torn fibers here. You can kind of think of it like when you're tearing a rope, and if a rope were going to tear on you, it kind of leaves a kind of torn in strands. And so what we do is we kind of clean that up there. There's various ways to rebuild your ACLs. You can take your patellar tendon, which is the tendon in the front of your knee, take your hamstring tendon. There are some newer talks about fixing these. This one would not be really amenable fixing, but if you caught it early and it was torn in the top here, there's a chance that you could fix it by sewing it together primarily. Here's the bone tendon bone, or the patellar tendon. It's the gold standard as far as reconstruction here. We take a little bone dowel from your kneecap here, and we fix it with a screw that actually is absorbable. And this is the new graft here, or your ACL. And then on the tibial side, you can see that there's a graft here with the screw. This is a newer technique where you basically take your hamstring tendon and put it over 2 buttons and suspend it. It's a good way to help rebuild the ACL graft too. And so here's the torn ACL here, and what we do is we drill holes where the ACL used to be here. This is on the femur, this is on the tibia, and then we reroute a new graft in between them to make up for the torn ACL. This is what it looks like on x-ray. We have 2 buttons that kind of help suspend the graft between the ACL, between the femur and the tibia. As the other cruciate would be the PCL. It's a restraint to posterior translation. It's twice as strong, as thick as the ACL. 2 bundles also. Here's a cartoon of it torn here. This is what it would normally look like on an MRI here. A lot of these PCL injuries can be fixed with just rehab alone. If not, then we may have to talk about reconstructing it. Usually it can tear with other ligaments inside the knee. And It's important to know the anatomy. Here is the insertion of the PCL, and usually we get a little X-ray of it so when we rebuild it. Your ACL recovery, usually you can be full weight bearing unless you have other ligament injuries. PT, and usually full recovery 6 to 9 months. Same thing for your PCL. Usually you got to slow down your PCL rehab a little bit further, so you may be on crutches for about 6 weeks or so, and partial weight bearing. Then we're going to move on to the collaterals, or the ligaments on the outside. A frequently torn ligament would be the lateral collateral ligament, or the LCL. Varus laxities can be injured with the posterolateral corner, and here it's a schematic of it here. Here's a view of a reconstruction. This reproduces the LCL here, and then the posterolateral corner. The other collateral that can be frequently injured would be the MCL. Most of these can heal without surgery. And usually it's with PT and a brace. Occasionally you need to repair it or reconstruct it, and that's the ligament on the inside here. Rehab, the LCL's crutches for usually 6 weeks, non-weight bearing 4 to 6 months for full recovery. MCL 6 weeks, non-weight bearing, and 4 to 6 months. And it's important that you do PT for both of them. On to patellar instability, or your kneecap dislocations. Here's a view of your kneecap being dislocated on the side. There's various reasons why your kneecap can dislocate. A lot of times it's because you have loose ligaments. You can have it from trauma, or not really having a trochlear groove where your kneecap sits in. Typically when you dislocate your kneecap, you have an injury to the medial patellofemoral ligament, or the MPFL. It's the most important stabilizer from 0 to 30 degrees. The attachment on the patellar is on the superior half. On the femoral attach, it's the saddle region between the medial femoral canal and the adductor tubercle, also known as Schottle's point. And here's an X-ray image of it here. And here's a little cartoon of how we rebuild the medial patellofemoral ligament to keep your kneecap stable. Here's a view of the kneecap. Here we typically drill 2 holes in the patella, attach it to the patella with 2 anchors, and then take a graft here and secure it to the femur, and that keeps it as a nice check ring and a leash to keep the kneecap from popping out laterally. Usually you can be full weight bearing in a brace. Rehab's usually about 4 months of PT until we can get you back to doing everything you like doing. And then the extensor mechanism disruption would be your injuries to your patellar tendon, your quadriceps tendon, and your kneecap. Usually cause either a direct fall on your kneecap or a strong muscle contraction, such as jumping. And here's a little cartoon of a tear of the patellar tendon. Usually requires surgery, and usually you can't lift your leg. And the way we usually fix it is typically we drill some tunnels through the patella, run some suture through and tie it over the top. The newer way I've been doing it is with anchors, where we don't have to drill all the way through, and we place a series of 2 to 3 anchors at the bottom pole of the patella here, and then run suture through and repair it back. Usually you're full weight bearing. It's an outpatient surgery. We get you into PT a few days afterwards. 6-month recovery occasionally can be a little bit longer depending on what kind of activities you like doing. And the patella fracture here, as you can see here, the kneecap is broken in a bunch of little pieces, and what we do is you run a bunch of wire and suture through and get it back to looking normal. And this helps to restore the extensor mechanism so that you can straighten your leg and go up and down stairs. Rehab is similar to patellar tendon and quadriceps tendon tear, usually full weight bearing with crutches in a brace, usually locked out. Well, that concludes our talk. Be happy to answer any questions. Acutely, ice does. It helps take down the swelling, and as long as you don't have any kidney or stomach issues, ibuprofen also helps also. And you know, the age-old adage of RICE, which is rest, ice, compression, and elevation, still works. So if your knee is acutely injured, I'd recommend ice. It keeps down the swelling, it helps with the pain, and to keep it wrapped, and the ibuprofen helps and keep it elevated. Yeah, I think the exercising and the stretches that, you know, we all learn in PE growing up are great exercises to do. So, you know, definitely warm up and, you know, stretch the hamstrings and the knees and the quads and the glutes can be very helpful. Yes, there are. Depending on the type of meniscus tear, some meniscus tears that we would consider your degenerative meniscus tears have been shown to do just as well with physical therapy and injections as with surgery. That's a good question. Depends on what you're using PRP for. If you're talking about using PRP for knee arthritis, the papers that I've seen have shown it to last for 2 years or so. If you're using it for tendonitis or whatnot, I think 6 to 9 months would be a good result. Depends on what you want to do. If you're talking about running or pivoting sports, usually it's 6 to 9 months. If you're talking about working out, if you're just going to do some upper body, you can probably do it like 2 weeks afterwards, as long as you're moving around safely. But if you're talking about doing some heavy duty lifting, lunges, squats, it all depends on whether or not you injured your meniscus or any other injuries. And I would say that everyone is a little different and individualized, and it's hard to put a blanket statement on that. But I would encourage you to talk to your physician. Runner's knee. So runner's knee, if we're talking about the same thing, is typically a constellation of symptoms where you have pain in the front of the knee exacerbated by running. Typically, the evaluation would have involved talking about it, the feelings where you have the pain, and then an evaluation is usually localized to the front of the knee. Can be associated with some swelling. And typically it gets better with anti-inflammatories and some PT. As far as runner's knees, it's usually kind of an overload to the patellofemoral joint that does get better with PT and some rest. Yes, you can have it repaired more than once. Depends on what it looks like the second time around. A lot of times after the first time, the meniscus gets pretty beat up, but it can be repaired 2 times. But the chances of that happening successfully are pretty slim. The symptoms of meniscus tears typically are popping, clicking, catching, and then medial lateral joint line pain, and pain with twisting. So if you find that twisting your knee, squatting down causes pain in your knee, then it may be meniscus. If your knee gets stuck where you can't bend it or straighten it, that could be related to your meniscus also.